Obesity is common, and the pregnancies of patients with obesity and placental complications are at an increased risk of stillbirth. Research has shown that the axes of placenta are modified independently and therefore reflect different mechanisms. Thickness, surface, and shape of placenta are modified by both maternal and fetal factors. We therefore carried out this retrospective chart review in order to compare the placentas of pregnancies resulting in stillbirth to those of live births born to females with obesity and normal weight based on their pre-pregnancy BMIs. Information on all patients with a stillbirth at greater than 20 weeks gestation at Kingston General Hospital from January 1, 2010 to December 31, 2019 was collected, and case control matching was performed in a 1:3 ratio. 3 obese ppBMI and 3 normal ppBMI controls were selected based on maternal age, parity, and gestational age. Patients with missing data, multiple gestations, or known congenital anomalies were excluded. This resulted in a comparison of 30 stillbirths to 90 normal ppBMI controls and 90 obese ppBMI control patients. Placental weight, length, and width was collected directly from charts, while surface area, thickness, degree of ovality, ratio placental width to length, and ratio placental weight to birth weight was calculated. Due to limitations in the size of the database, and that most pregnancies without serious complications are not delivered at early preterm, matching of controls was done by term versus preterm and not specific week of gestational age. As such, it is not surprising that gestational age varies significantly between live births, control groups, and stillbirth cohorts. Additionally, the larger proportion of males seen in the stillbirth cohort is expected based on literature, though this difference is not significant. Birth weight varies significantly between stillbirth and live births when compared to obese ppBMI females, with larger babies seen in the obese ppBMI cohort. Birth weight did not vary significantly when comparing normal weight ppBMIs to stillbirths. No p-values of maternal conditions reached significance, though this was likely limited by the small sample size. Ethnicity and maternal weight gain over the course of pregnancy was not collected and therefore is an uncontrolled confound. The ethnicity of the patient population served by KGH is predominantly Caucasian and homogeneous. Placentas of stillbirths were significantly smaller across all dimensions measured than those of live births except thickness. After adjustment, only placental weight and length maintained statistical significance. The ratio of placental weight to birth weight never significantly differed between the different groups before or after adjustment, suggesting that placental efficiency does not differ between these populations and is not a factor in these stillbirths. It is unknown whether these relationships are direct or indirect, and there are currently very few antenatal interventions with good proven effects on pregnancy and birth outcomes, and this study is an early starting point in the process of identifying patterns and placental phenotypes in the hope to use these phenotypes for risk prediction and potential targets for interventions to improve maternal fetal outcomes.